Hello and welcome to another edition of Cardiac Imaging Agora. I have the pleasure in this session to introduce my good friend and colleague, Dr. Christine Jellis. Christine is the Associate Program Director for our Imaging Fellowship. Besides being a fantastic clinician, she's a multimodality imager, trained in echo, CT, and MRI. She is actually down the hall from me right here. And today she's going to discuss with us multimodality imaging in cardiac sarcoidosis. Thank you, Christine, for volunteering your time.
Thank you, Wael. It's such a pleasure to be here, and I hope that everyone's doing well during these uncertain times. Today's talk is going to be on cardiac sarcoidosis, obviously with a focus more on MRI. We're mindful of time, so I'll allude to PET, but that may be a follow-up talk. So when we think about Sorry, I'm just trying to advance the slides there. So when we think about causes of underlying infiltrative cardiomyopathy, there are multiple causes that we can potentially need to evaluate and exclude. We know conditions such as hypertrophic cardiomyopathy, amyloid, oxalosis, hypertensive heart disease, lysosomal storage disease, Friedreich's ataxia. They can all have a similar appearance on echo. And today we're going to focus our talk on cardiac sarcoidosis, which I would include in this group. And I think the utility of MRI for tissue characterization is really important, particularly in this condition and many others that I've described here. So when we think about cardiac sarcoidosis, sometimes it feels like we're actually in the middle of an epidemic of sarcoidosis because the numbers really seem to be increasing quickly with time. But as you'll see here from this Finnish study where numbers have risen over 25 years, it's probably not so much a case of the disease prevalence increasing, but just that we're getting better at detecting the disease. And this is where multimodality cardiac imaging has really come to the fore. We know that endomyocardial biopsy, while in some cases can be useful, overall does not have a particularly high strike rate, with non-caseating granulomas really only detectable in less than 25% of patients with cardiac sarcoidosis. There may be some new electroanatomic mapping techniques that can be used to increase this yield up to 50%, but really it's not proven to be as useful as we would have hoped for diagnosis in many of these difficult and challenging cases. So this is where there is a great importance for advanced cardiac imaging to make the diagnosis. And there has been, as you I'm sure would appreciate, some controversy regarding the best approach. So when we think about cardiac sarcoidosis in the setting of pulmonary or systemic sarcoidosis, for most patients, it's a clinically silent disease manifesting in only about 25% of patients. But as I remind most of my patients, in only 5% of that group will we see clinical manifestations. In those settings, though, the manifestations are typically cardiac, with predominance of symptoms like heart block, ventricular tachycardia, and heart failure. So while this may be a major concern for patients with sarcoidosis and physicians looking after them, the actual numbers with symptomatic disease remain low. But as you can see here from this study looking at patients with cardiac sarcoidosis, the ability that we have to detect underlying disease really varies by technique and often cannot be diagnosed accurately until the time of transplantation or autopsy. So this is where we need to rely on imaging modalities such as MRI, which can increase our ability to detect asymptomatic cardiac involvement in sarcoidosis by up to around 54.9%. So what we're doing is making the invisible visible. Now, most of us in imaging labs across the world still rely on echocardiography, and I want to mention that because it remains our workhorse for initial evaluation of these patients. It's the typical screening imaging tool for patients with suspected cardiac sarcoidosis or extracardiac sarcoidosis, and we rely on our 2D images to look not only for regional wall motion abnormalities and focal aneurysms in a non-coronary distribution, which we'll talk more about, but other features such as LV enlargement, systolic dysfunction, pericardial effusions, diastolic dysfunction, and we are able to localize the region of these abnormalities to try and hypothesize whether cardiac sarcoidosis is involved. As on autopsy, we know that the basal interventricular septum has the largest percentage of macroscopic involvement, followed by the basal posterior wall and lateral wall. So in the absence of coronary artery disease, if you see regional thinning and hypokinesis of the basal interventricular septum, then that is really quite specific for cardiac sarcoidosis and can be associated with poor long-term outcomes. So echo, when compared to the Heart Rhythm Society criteria, has good specificity but poor sensitivity when we think about identification of cardiac sarcoidosis. One thing that has really improved our ability to detect sarcoidosis is the use of echo strain. And this elegant study by Emma Joyce showed that you could use 17.3% as a cut point on strain for likelihood of identification of patients with cardiac sarcoidosis who had extracardiac sarcoidosis. And you can see here on the polar maps there, the area of pink as opposed to the red shows you a region of reduced strain, which in this case is in the mid-lateral wall corresponding to where there's likely to be granulomas. We can see that strain performed better than diastolic dysfunction as measured by E prime, and also 3D ejection fraction as stratifying patients with evidence for cardiac sarcoidosis. And when we compare strain with our gold standard, if you like, imaging modality being cardiac MRI, there is a relationship to delayed enhancement. So we can see that those with reduced strain tend to be the patients who have positive delayed enhancement on their MRI, as opposed to those with normal strain who have no delayed enhancement. However, the sensitivity and specificity remains somewhat poor compared to MRI. So cardiac MRI has really come to the fore, and it's become our standard of care to diagnose cardiac sarcoidosis. In addition to, I'll mention cardiac PET, which we'll talk a little bit about later. So the regional wall motion abnormalities and aneurysmal wall thinning that we appreciated in a patchy non-coronary distribution on echo is certainly something that we see with cardiac MRI. However, there are other features on tissue characterization that makes this a much more sensitive and specific technique. So specifically, we're looking at the T2 edema-weighted sequence where we see increased myocardial signal intensity. And as I mentioned earlier, delayed gadolinium enhancement imaging, where we see uptake of gadolinium in regions of scar or inflammation. You can see here in the figure, and I've circled the areas that are most typically involved with cardiac sarcoidosis. As you can see, the basal interventricular septum, the basal inferior, posterior, and lateral segments, as well as the mid-infroseptum, inferior wall, and posterior wall. Obviously, it can occur everywhere, as you've seen with the percentages here, but those are the most commonly affected segments. I also want to share this figure with you that illustrates how the increased signal that we see with delayed enhancement and edema-weighted imaging can be in a transmural distribution, a subepicardial distribution, a subendocardial distribution, or a mid-myocardial distribution. So I like to refer to sarcoidosis as being the great masquerader. We can really see it anywhere in any distribution, and you need to keep it on your radar as a potential differential diagnosis. So here we've got some delayed enhancement images where we can see areas of uptake of gadolinium. And you can see that this can be in a focal distribution, as we see here in the anteroseptum and anterior wall. It can be multifocal, where you've got multiple areas of uptake of gadolinium, and this can be focal on diffuse and then progress to more of an extensive uptake, as you can see here, through multiple territories. So you appreciate how even in different individuals with the same pathology, how the spectrum is quite broad. You can see here a nice example of delayed gadolinium enhancement here in that inferior and posterolateral wall, and hopefully it projects that you can see in the same area of distribution increased signal on the edema-weighted T2 stir sequence corresponding to an area of active inflammation. In an area of scar, we may see the delayed enhancement, but we would not necessarily see this increased uptake on the inflammatory sequence. So that can be a useful modality to differentiate between the two, but because of reduced sensitivity, we always think about moving on to cardiac PET for assessment of underlying inflammation. So you can see here when we compare cardiac MRI to transthoracic echo and also to other criteria, here being the Japanese Ministry of Health criteria, that it really performs very well with respect to sensitivity and specificity for diagnosis of underlying cardiac sarcoidosis, and hence is why it's our go-to modality. You can see here in a similar illustrative way how cardiac MRI here really outperforms all these other modalities for screening for underlying cardiac sarcoidosis in terms of ECG, Holter, echo, and the Japanese criteria. So it's really an outlier here, outperforming everything else. We also know in the right-hand panel that when we have patients with delayed enhancement, that is also a very good differentiator to think about probability of survival. And you can see here that those with no delayed enhancement are likely to do much better. I want to just mention device-associated MRI artifact, because I think, unfortunately, by the time we see a lot of patients, they've already had a pacemaker or ICD implanted for heart block or VT when cardiac sarcoidosis was not considered to be a differential. I think these days with MRI compatible devices, as you can see here on the left, it is still very possible to get good image quality despite there being a pacemaker. Whereas compared here on the right, obviously there's a large artifact from the generator. So I think always reach out to your imaging expert at your institution to have these discussions, give them a heads up about the patient having a pacemaker, and see what they can do to optimize their sequences to make sure that they get you the best diagnostic quality images. So I've got a couple of examples for you now, and I hope that you'll find these of interest. Here we've got a patient with normal ejection fraction. We can see here normal contractile function of both ventricles. We look on their strain profile here, and we see though that despite normal ejection fraction on this MRI cine sequence, we have a reduced global longitudinal strain of minus 13.9, so certainly below Dr. Joyce's cutoff of minus 17. And you can see here on the polar map that there's reduced strain in those basal posterolateral areas and also in the basal septum. And then nicely on the delayed enhancement sequence here, you see illustrated with delayed enhancement the uptake here in the septum and the basal to mid lateral wall corresponding to the areas of reduced strain. So you can imagine if we relied only on the echo or the MRI cine images that we may miss the likelihood for cardiac sarcoidosis in this patient. Perhaps a more extreme example, here we see hypokinesis in the mid-lateral wall with a reduced ejection fraction. Again, we see reduced strain in this area, both in the basal septum and the mid to basal lateral wall, reduced strain of minus 14.8. Hopefully you can see this cine image here for MRI, which has got some hypokinesis in a similar way to the echo 4-chamber view, where you have reduced function there, and then corresponding thinning and increased delayed enhancement in the mid-lateral wall here and also in the basal infroseptum. So perhaps a slightly more obvious case. That brings us to this really elegant example here where we've got an echo 2-chamber view here where you've got these bite-like aneurysms in the basal and mid-inferior wall with a reduced ejection fraction of 45%, corresponding reduced strain, although overall there was still a relatively good strain value given from a global perspective. But then on the MRI image here, you can see that you've got these bite-like areas of hypokinesis aneurysmal formation in the inferior wall in a similar way to what we saw on the echo image, which corresponds to these regions of focal delayed enhancement, which is not in a coronary distribution per se and would be very suspicious for cardiac sarcoidosis. And perhaps my favorite example to show you here, where if you saw this echo image here with this thin bite-like aneurysm in the mid-infroseptum, classically a non-coronary distribution. If you saw this in your echo lab, you would be very suspicious for cardiac sarcoidosis, despite the fact there's a normal ejection fraction corresponding here to impaired strain. And then these beautiful MRI images here where you've got similar findings on cine imaging with that focal delayed enhancement. And so these, from a multimodality perspective, are lovely illustrative cases. Another case here where you can see really that diffuse uptake, sort of focal on diffuse with the reduced strain, and then these quite lovely MRI delayed enhancement images. What we don't know from this is how much of this delayed enhancement is permanent scar versus active inflammation. And so I think that is probably a weakness in the area of MRI, that we do get some indication of this from the T2 STIR sequence, but often we then rely on cardiac PET scans to give us more information about inflammation. So think of it as a spectrum of imaging findings where you move from 2D echo into cine MRI to look at function, progressing from normal to focal hypokinesis, focal aneurysms, and then more of a dilated cardiomyopathy. Use strain echo for risk stratification, where you can then move from normal strain into extracardiac strain, which may manifest with reduced strain in the early phases of cardiac sarcoidosis, and then significantly reduced strain in the setting of more overt cardiac sarcoidosis. Lastly, we move into cardiac MRI with delayed enhancement imaging, which can be normal, which can show mild burden, suggesting perhaps early disease, and then more extensive burden in more progressive disease, although, as you can see here, PET may be useful at this point to determine disease activity and then response to treatment. So just some slides here looking very briefly at PET, thinking about stratification of cardiac sarcoidosis based on perfusion defect and associated FDG uptake. And then one last case to finish us off. So a 45-year-old man presenting with complete heart block. Here on the PET, you can see he's got obvious uptake in those same areas that I described on MRI, those sort of basal to mid, inferior, lateral, and septal areas. You can see here that on whole body PET, he's got increased uptake in the lymph nodes, which enabled us to biopsy these and diagnose the patient with non-caseating granuloma. He was treated with steroids, ended up having CRTD, and did extremely well. So I think that's a nice illustrative case. A shout out to the importance of dietary preparation for sarcoid PET. I'll include these slides for completeness, but look forward to hearing a further presentation which will include more information about this. And I think that is really an important thing when you're preparing patients for PET, to make sure that they do their dietary preparation, because as an imaging cardiologist, the last thing I want is for a non-diagnostic study. So the take-home messages today are that the lack of a reliable gold standard emphasizes the importance of multimodality advanced imaging for consensus. Now, this can sometimes lead to controversy, and it can make clinical decision-making difficult. So seek out your sarcoidosis expert at your institution. They will guide you about which multimodality aspects of imaging can be useful, and those that making the invisible visible really becomes a lot easier when we're getting different layers of information. So patients with isolated cardiac sarcoidosis may be subsequently found to have abnormal mediastinal lymph nodes on this multimodality imaging, which will allow you subsequently to get biopsy diagnosis to enable you to confirm this diagnosis. And there really is a need to evaluate for disease activity, so degree of inflammation as well as underlying scar. MRI can assist you with this, and this is where building upon that MRI information with cardiac PET can be incredibly useful. And as I've alluded to, make sure that you discuss these patients with your imaging experts so that they're well prepared if they do go on to have a cardiac PET, so that you get the most information that you possibly can. So I think this is a really interesting disease process. We're well placed with multimodality cardiac imaging to help you make the underlying diagnosis. And the importance of discussing these patients with your imaging specialist cannot be more highly recommended, to make sure that we do the right testing for the right patients. But thank you for the opportunity to present. It's been a pleasure being with you today.
Thank you, Christine. This is fantastic. You know, there's never a time when I don't learn from this. You know, you and I work in the same area, and then we discuss these patients often and all the time, given your expertise in echo and MRI and my focus on echo and PET in these patients. I just a couple of things that I thought about, because my first encounter with this disease, probably my first memory of it, is a patient who had all the features of cardiac sarcoid, was diagnosed with cardiac sarcoid. Right before we implant an ICD in this patient, one of my colleagues in EP thought about getting a cardiac cath on this patient. And it turns out that the patient also has triple vessel disease plus cardiac sarcoid. So it's the nightmare. So do you recommend that we do anatomic imaging? I know your expertise in cardiac CT. Do you recommend we do just at least, especially that this population tends to be on the younger side? We've seen older patients with sarcoid, of course, but the younger side. Do you recommend like a CT coronary angio just to get that out of the way as an initial step?
Look, I think it's a really good idea. Sometimes it's incredibly difficult, depending on the pattern of delayed enhancement on MRI, to be 100% sure that you're not dealing with underlying coronary artery disease. I think taking a step back and looking at the patient and their pretest probability is important. If they've got cardiac risk factors, I think it's very much indicated to work them up for underlying coronary disease before we label them with a diagnosis of cardiac sarcoidosis, especially as the treatment options are so vastly different, and we would not want to miss that diagnosis in this patient population group. So I think the CT coronary angiography in the younger patients is very much worthwhile. I think for the older patients who may have underlying coronary calcification, then perhaps more of a functional test may be useful. But I think definitely something to consider.
Another question for you, Christine. Thank you. This is fantastic. Another question is, when you're seeing these patients, like how did you, like we're all trying to minimize the number of tests we do on these patients. I think cardiac sarcoid is one of those rare instances where we cannot be stingy with tests on these patients, because as you showed beautifully, the layering of the imaging and the layering of the clinical information, the EKG. So you're seeing a person fresh with a, let's say, an EKG with normal sinus rhythm, first degree AV block, right bundle branch block. So you start with the echo, and then how do you move from there? Let's say I'm going to give you a hypothetical question, 51-year-old female.
It's like you were in my clinic yesterday. So I think this is the typical patient that we see. And obviously we're seeing a biased sample. So often they've got an underlying EKG abnormality when they come to us. This is where the data that we're collecting at the moment will hopefully guide us with some workflows in the future that are going to be able to be applicable to other organizations, because there is a lot of variability in the way that people screen for patients with cardiac sarcoidosis. But I think if there is an underlying abnormality on that initial baseline EKG, it's very reasonable to proceed with an echo. If there's any abnormalities on the echo, including reduced cardiac strain, I would then suggest moving ahead with a cardiac MRI, doing not only the cine images, obviously, but the edema-weighted sequence and the delayed enhancement imaging, to give you more of an idea about underlying smaller granulomas that may not be impacting so much on gross LV function, but that if you were able to pick that up early, may be able to be treated and have an impact on the patient's overall morbidity long-term if you're able to institute therapy sooner.
Fantastic. Any last points you want to mention to our group here? We have fantastic, wonderful young fellows who watch this. Of course, they're going to get excited about getting into cardiac imaging after they heard you. Any last points?
Look, I think cardiac sarcoid is really exciting because I think it's one of the areas that we don't know everything about. There's so much still to know about it, and a great opportunity for people to do research in this area, particularly from an imaging perspective. Our databases, I think we're building slowly, but I think there'll be a lot of opportunity to correlate the different multimodality imaging, obviously from an intellectual perspective, but also to do the best by our patients, because a lot of these patients tend to have a delayed time course between the onset of their symptoms and when the diagnosis is made, which leads to a lot of unnecessary suffering and perhaps long-term consequences. So the more awareness we can get out and the more accurate we can be with our non-invasive assessments, I think is good for everyone. And I'd just like to give a shout out to our cardiac sarcoidosis team, because we have specialists from lots of different modalities who come together to discuss these patients. And it really is shared decision making. We share our hypotheses, we share our results, and we then come together to develop the likelihood for the diagnosis and also a treatment plan that's specific for that individual patient. So I would highly recommend working in that sort of environment, which is collaborative, because there's no patient that goes past without us learning something from them. It makes certainly work more exciting and enjoyable, but it also feels like we're then contributing something back. So it's a real pleasure to be talking to you today. And I look forward to hearing more on this wonderful platform about cardiac sarcoidosis.
Thank you, Christine. Have a great day. Thank you.